for a detailed insight regarding glucocorticoid replacement in adrenal insufficiency. The next topic is about adrenal incidentaloma, the challenging cases. The speaker of this session is Dr. Tamar Saeed from UK. He is Associate Professor and Head of Department of Medicine and Endocrinology. He is the Program Director of MTI in collaboration with College of Physicians and Surgeons, Pakistan. A warm welcome to Dr. Saeed Tamar.
Thank you very much for giving me this opportunity to talk to such an esteemed and knowledgeable bunch of people. I've got 20 minutes. I'll try to squeeze as much as I can. I've got a few interesting cases to talk about today. And I'll start with the first one with a broken heart. I've got this 58 years old gentleman who presented feeling generally unwell and has been complaining of some neck pain. And he has been complaining of sweaty, shaking, feeling cold and clammy at times. And he's been also complaining of some pain in the neck as well. His past medical history includes hypertension, ischemic heart disease. He's been on aspirin and AC inhibitor and beta blockers. Examination-wise, this patient was pale, sweaty, and he was afebrile initially with a normal GCS of 15. His respiratory rate was a bit high, but oxygen saturations were normal and chest was clear. He had mild hepatomegaly on examination of the abdomen. He was found to have hypertension with a blood pressure of 205 by 107. His infective markers came back as quite high with a white cell counts of 28. And he had elevated liver enzymes as well. His CK was high and his troponin was found to be elevated. He had an ECG done, which shows some inferior lateral ST depression, and the chest X-ray was clear. So at this time, when the patient was seen, thought he had an acute coronary syndrome, he was started on an ACS treatment, and a cardiology advice was sorted at this time. He had a bedside transthoracic echo, and a CT angiogram was planned for this patient. Now, I mean, the differential diagnosis at this time coming to our mind whether this patient had aortic dissection. He had some pain in the chest radiating to the back, and he had a bit of a blood pressure difference in both arms as well. Whether he's had an NSTEMI on the basis of the presentation and the raised troponin levels, he's had a thyroid storm, or whether he's got a pheochromocytoma. So, as he was started on a treatment for ACS, he had a first day, we've looked at it, he had a repeat troponin done on the same day after 6 hours, which came back as over 2000. He had a bedside echo done, which showed severe LV systolic dysfunction with the anterolateral hypokinetic wall. And there was no dissection found on the aortic root on echo findings. Now, he was put on a fluid restriction because of the heart failure. He was commenced on ACS treatment and statins along with the lisinopril. Now, on the next day, he became quite unwell, became more sweaty, clammy, and his blood pressure came down at this time. He had an episode of tachycardia with the heart rate went up to 140. His infective markers were still high, but his creatinine started rising at this time. He had normal thyroid functions, and we had to hold the lisinopril because of his one worsening kidney function. The second thing, his blood pressure started to come down. He had a CT angio was done, which showed this left adrenal growth, and we were not exactly sure what it is, but looking at the presentation of this patient, the way he presented, initially hypertension, then coming down with the blood pressure after the GTN infusion, and he was thought whether he's had a pheochromocytoma. He was commenced on phenoxybenzamine, and blood cultures and rest of the infective markers were sent for this patient. Now, the next day, his blood pressure dropped further to 85 systolic. He's still tachycardic, and at this time, we all can see that he's probably in septic shock. He was transferred to HDU. His platelets started to drop. D-dimers were raised, and whether he's got that DIC type of picture. His thorium was fluctuating and was dropping as well at this time. So, in view of the current presentation, because of the low platelets and the low blood pressure as well, his ticagrelor and fondaparinux was held. His aspirin was stopped at this time. IV fluids were given very cautiously at this time because of his heart failure. He was commenced on tazocin, and his blood cultures came back that time, which showed gram-negative rods. So here's the patient. We've got the problem list with him. He's got an NSTEMI. He's got a severe heart failure. He probably has got pheochromocytoma. He's got sepsis of unknown origin. He's an acute kidney failure, whether he's got a DIC as well or not. He's got hyponatremia. So following up with the hospital stay, he started to show some improvement. Blood pressure started to pick up. His infector markers started to come down, and the echo findings, we are aware of it. Now, the blood cultures came back positive for Capnocytophaga canimoris, which is quite an interesting bug. We've really heard about it. His ticagrelol was restarted because of the suspected ACS. His coronary angiogram was done, which showed two vessel disease. He was discussed in a cardiology MDT, and there was no strong indication of cabbage at that time, but that he can be considered for PCR or cabbage in the near future if he develops symptom. He was discharged. But finally, the blood test, the urine test, which was sent on during the hospital admission, because they take some time to come back, he had quite elevated metanephrines and catecholamines. So the current diagnosis of this patient, then with the NSTEMI and severe heart failure, he has got pheochromocytoma. But then looking it further into this case, because he had pheochromocytoma with quite high levels of catecholamines, this patient has got Takotsubo cardiomyopathy, and along with that, he had a sepsis secondary to Capnocytophaga canimoris. He was planned for adrenalectomy and probably cabbage in the future. Now, this patient had an adrenalectomy done in a few months down the line. His histology came back as showing a very well smooth circumscribed adrenal nodule, which is of pheochromocytoma. Now, we went back a little bit in the history, because coming back to the same basics, that this patient, what happened, and then digging a bit more in the history, he did mention that he had a dog bite about 5 to 6 days before he came to the hospital, and that's when he presented it. So again, there was some missing information from the history, which of course caused a bit of delay in the treatment. So this is a very unusual presentation. It was described first in 1976, and then in 1989 was given the current name. It is part of this oral flora of the canines, but very rarely with the cats, and it responds very well to the penicillin. Takotsubo cardiomyopathy, of course, is a reversible cardiomyopathy. It can happen because of the stress and high levels of catecholamines, and the name was given to it because of the Japanese octopus trap, which is called Takotsubo. So in summary, this was a unique case of a patient who presented with pheochromocytoma crisis accompanied by transient severe LV systolic dysfunction, which could be part of the Takotsubo cardiomyopathy, who developed a life-threatening sepsis and septic shock secondary to Capnocytophaga canimoris, followed by the dog bite. I'll move to the case 2 because I need to talk about a few other cases as well. So this is another interesting case. We had a pregnant lady, a lady who was 26 years old female, who was referred to the endocrine clinic because she was referred by a gynecology team, was investigated for infertility, and as part of the investigation, she was found to have a hypoechoic vascular pelvic mass. The only past medical history included a B12 deficiency. She was referred to endocrine because she was initially investigated for IVF as well. So in her first pregnancy, she had an intrauterine death at the 8th gestation month, and that is the time when she was found to have this hypoechoic mass. In the second pregnancy, from the early gestation, she developed some headaches, sweating, palpitations, followed by uterine contractions as well. And she also mentioned that she developed these symptoms when she goes to void, and the blood pressure drops at times as well. But she had a normal delivery. She had the same episode continued after the delivery, and with the third pregnancy, she had a miscarriage at the 6 weeks of gestation as well. So these symptoms all developed a year after the first pregnancy, with palpitations appear to be not connected to micturition initially, but she started to experience them with hematuria and micturition as well. So when this mass was found, she was planned for surgery, as it was not really connected to the adrenals, and they thought it could be a pelvis mass. We can remove that. and was during the surgery, quite an interesting thing happened that as soon as the mass was touched, the blood pressure went up quite high to about 200 systolic, and they had to abandon the procedure. They just managed to take the biopsy of it, and then they had to stop the procedure. And then that was the time. But then they thought about it. I think a bit more endocrine input is needed in this patient. Examination was normal, apart from a mild apical systolic murmur. Glucose was normal. All the investigations came back as normal. She had a 24 hours urinary catecholamines, and that was found to be elevated with a normal ECG. Echo was normal, and we looked for the fundoscopic examination as well, which came back as normal. CT scan of the chest was normal, and that is the mass she was found to have on the CT scan of the abdomen. She had an MIBG scan done, which showed quite an area of the pathological uptake in the right pelvis, and which anatomically matches with the CT scan findings, with an additional small uptake connected to the urinary bladder from the right side. So she was commenced on a treatment. All the symptoms were resolved after starting on phenoxybenzamine and propranolol. The mass was attached to the right ureter and surrounding, and it was invading it as well. So all the symptoms resolved after the surgery. She was planned for a surgery under proper endocrinology review, and after the operations, her medication was stopped and her symptoms resolved. So she probably had a familial paraganglioma, which most often happen in the head and neck, but can also be in the thorax, abdomen, and pelvis, and the urinary bladder. So most causes are caused by a mutation in the SDH subunit genes. Pheochromocytoma in pregnancy becomes quite challenging, and and effects are uteroplacental insufficiency, which causes spontaneous abortions. Maternal hypertensive crisis can lead to the fetal hypoxia and death. In terms of the mother, the effects can be maternal collapse and death of the patient. Now, the patients with the pheochromocytoma, if they are diagnosed during the pregnancy, the treatment is to commence them on alpha blockers as soon as possible and plan for surgery in these type of patients. Now, this is a unique case of paraganglioma with the involvement of the ureter that was presented. The natural history of the tumor growth and symptoms appearance during and after the pregnancy and its possible contribution to infertility has been described. The tumors are associated with high incidences of persistent and recurrent diseases and increased malignancy rates. But unfortunately, this patient lost to follow-up. She was planned for further follow-up, but she didn't turn up, and it's unfortunate that we have lost her from the follow-ups. I'll talk about the last case, which is a tale of a stressed out gland. So this is a patient who presented, who's a 28 years old female, who was a science teacher, who has a history of depression and anxiety. She was, the only medication was sertraline, and she was on COCPs. She presented to the surgical team initially with a right flank pain, and whether she has got renal calculi or biliary colic. Routine blood tests were unremarkable, but she had a CT scan of the KUB to look for any renal calculi and as a cause of the pain. However, it showed that the bulky left adrenal gland, which was measured quite large in size, actually 35 by 20 to 53 millimeters. There was nothing in the clinical history to suggest any over-secretion, hyper-secretion from the adrenal gland. Her biochemistry was not supportive of that either. She had normal metanephrines, she had normal aldosterone-renin ratios, although she failed overnight dexamethasone suppression tests initially, but that is mainly because the patient was on COCP. But subsequently, she had 24 hours urinary cortisol and a salivary cortisol, which all came back as normal. ACTH was normal, which actually rules it out whether it could be any hypersecretion of cortisol from the adrenal glands. Now, this is the MRI scan and the CT scan findings as well, which showed the adrenal tumor. Now, what would you do here in this sort of situation? Of course, there is no hypersecretion, but the patient was quite anxious, and during the clinical consultation, she was fixed about the possibility of this being an adrenocortical cancer. She was counseled in the clinic, reassured, but of course, because of the size of the tumor, we mentioned to her that she will require a surgery, but it is likely a benign. But given the size of the tumor, she would require surgery. She collapsed during the consultation and had a panic episode and wanted this to be sorted as soon as possible because of the history, and she wanted this to be sorted. Of course, in the NHS and things are not as quick. We can get it done. There is a waiting list. There is a timeline we need to wait for, but the patient did not want to wait for it, and during the consultation, she collapsed. She had a review, but the same day, because we had to had a chat with our endocrine surgeon just to address her anxieties as well. And then we planned for the surgery, which initially thought will be 3 months, but then because of the anxiety and the patient was quite pushing for it, we planned for the surgery. So she had a laparoscopic adrenalectomy was planned initially, but that was converted to open adrenalectomy because of the nick to the aorta, where she lost about 2.5 liters of blood. Major hemorrhage protocol was activated, and post-discharge she was then admitted again with constipation and vomiting, which was addressed accordingly with a symptomatic treatment. So an interesting finding on histology was found that a very well circumscribed encapsulated spindle lesion was found with no evidence of malignancy, and this was consistent of mature ganglioneuroma. And the plan is now just 12 monthly CT scans in this type of patients. So ganglioneuroma we've never seen in our practice in this area, but it's a very rare differentiated tumor originating from the neural crest cells. It's usually located in the retroperitoneal space and mediastinum, and sometimes can be in the cervical region as well. It's usually incidentally discovered, but because of the anxiety of this patient and the way she presented, she was lucky she had it operated. And the CT scan findings showed a very well circumscribed mass. Radiological findings were not specifically highlighting any challenges for a preoperative diagnosis. Um, so when we talked about the histology, of course, there was nothing suggestive of the malignancy in this patient, and she was counseled again that it's got an excellent prognosis. Of course, she's been counseled for any genetic testing, and we are still following her up. This is the case which we have just recently seen, so she's still under our follow-up, and we're planning for any genetic testing for it. Thank you very much.
Thank you, Dr. Tamar Saeed, for interesting and unique cases in adrenal incidentaloma. Uh, any question there in the audience?
I've got two questions. One for Khurshid. I mean, across the world, if you see various series, if you have presented in your slides as well, the percentage of the primary hyperaldosteronism is much higher than what we see in our practice, and this tells us that we are not screening them appropriately in most patients, which we should be doing. I think something that we endocrinologists should be blamed for than the internist, because if we are not doing it, then obviously the internists are not going to do it either. So something that we need to do in our practices. The only hindrance that really pushes us from doing it is the drugs that these patients are on. So even if these patients are on these drugs which may interfere with the renin and aldosterone levels, they should be screened first time, and then once it is positive, then you can look at whether you need to stop the drugs and re-investigate. So that is something that we need to. And the second thing is about the talk by Dr. Tasneem Hassan. I mean, this thing about the dose of hydrocortisone being too much really was, when I was being trained, when I went to BARTS in 1996, this was, they came up with this thing that the replacement total production is much less than what we are replacing in our patients. And the traditional dose of 20 and 30 was an overdosing. And they had started that practice of giving it 10, 5, 5 or 10 and 5. 15 to 20 was the replacement. One thing that I think we don't highlight, and that is the reason why our patients feel miserable when they wake up, is that they should keep their tablets on the bedside table. Take the tablet, whether it may be prednisolone, may it be hydrocortisone, they should take it and then give some time while on bed and then wake up, so that it is absorbed and they have the symptoms not that miserable when they wake up. So these are the two things that, and obviously in terms of dosage, I'm not a proponent of these high doses which have been previously given, 5 in the morning of prednisolone and 2.5. I've never used that sort of dose, but I've used 5 milligrams per day in the morning. But again, recently I was started giving 2/3 of that 5 milligram doses in the morning, once a day, to my patients. So these are two of my comments, and the interesting cases that you have shared with us, very complicated but very interesting cases, and I congratulate you for that.
Yeah. Thank you, sir, for your comment.
Thank you, Dr. Najib, for that comment. I don't know if I made it clear. So one strategy for that early morning deficiency of cortisol is what Dr. Najib said, that tell your patients to get up early in the morning and take it. But we're talking about a lifetime of replacement. So how many are going to get up very early in the morning and hope that the levels are going to build up? The other thing is that the peak level is at about 1.7 hours after taking the dose of hydrocortisone. So for that's a long time, and that's the time when everybody is on go go go, whatever you're doing. So that does not, taking it very early does not solve the problem, because remember, when patients wake up at 8 o'clock, they have the peak levels at that time, normally in the circadian rhythm. So we are not mimicking that. The 2 a.m. surge that starts peaks at 8 a.m. in the morning. So I don't know if I made it clear when we changed our strategy for our two patients. The 0.25 of DEX, we actually gave it at midnight. Midnight DEX and early morning half a tablet of 2.5 milligram prednisolone. And when we add it up, it's 25 milligrams. But if you look at the imperial group, they're using even lower doses of equivalence. So we are now going to shift 5 of our patients at a second stage onto a quarter tablet of dexamethasone at midnight. Fortunately, everybody sleeps very late in Karachi, so taking a tablet last thing at night is not a problem. I don't know how it should be replaced in people who sleep early. So maybe have an alarm and pop the pill at midnight, because then you give that time to get to that peak sort of level at 2 a.m. and then and then these are long-acting drugs, so it adds to the prednisolone as well that you give in the morning, because it's not over in the morning also. So together these two different synthetic analogs of hydrocortisone will kind of give you adequate glucocorticoid cover, provided you administer it in this fashion. And we tried it in these two cases. Now we have 5. I've just brought 2 here. Even our patient, 27 years of age, with CAH, with replacement right from childhood, pigmented as hell, very unhappy. She's doing so well on this regime of midnight DEX. The other question that I asked myself was, both are long-acting synthetic analogs of hydrocortisone, DEX as well as PRED. What about if we do a quarter of prednisolone instead of doing 2 different tablets? Just a quarter tablet of prednisolone at midnight and half a tablet in the morning. The problem there is that the prednisolone tablet we have is an oval one, which is scored in the middle, and then there's the enteric coated, which is a very small tablet, it can't be broken. So DEX tablet can be quartered and can be halved very easily, and that's why we chose to use DEX. I was also reading a study from the US where they took the injection dexamethasone and put it in capsules in very small amounts to use in the study. So that also seems realistically possible for us to be able to do that, like do a 0.1 milligram or 0.125 milligram dexamethasone solution in a capsule. But I think it makes complete sense to administer glucocorticoid in this fashion, because your patients are corrected, they're happy, and for us the clinical marker is pigmentation for the primary, and there's such a stark difference in pigmentation at the first follow-up visit. It is quite unbelievable how that pigment disappears in 3 months or 4 months after that. So
prednisolone. I mean, what is against, or what should be the fear associated with giving triamcinolone 40 milligram weekly or fortnightly? Second, can we consider, is it available sustained release of hydrocortisone acting as a basal for it? Thank you.
can you hear me? Yeah. This is the biphasic hydrocortisone is not available, but I guess you can get it in Dubai. It's very expensive. So most people don't take it for that reason also. It would be a nightmare to titrate if you did triamcinolone or all of those other longer acting things, because now we know that even slight over replacement, as you see in MAX, leads to increased morbidity and all cause mortality. So whereas you want to replace, but you don't certainly want to over replace. And what we've been doing with the way we've been using prednisolone and hydrocortisone is over replacing for the last 50, 60 odd years. So we need to go down on our doses, and we need to think about more physiological replacement. And how do you monitor it? The symptoms are very vague. So now we are doing in my own practice, what we are doing is doing prospectively before we switch. We are going to fill out a general health questionnaire. So have some kind of objective way of knowing how the patient was feeling, other than the pigmentation, which we can see straight away. And then look at, the only thing we can look at is, we can't do prednisolone levels. I wish we could, but at this point we can't, because there are targets to follow with prednisolone, which you can do elsewhere. But we can look at the ACTH levels. The only problem is that the ACTH level may be within normal range, and you may be slightly over replacing. So you certainly don't want to over replace, but monitor with the general health questionnaire and monitor with the pigmentation in primary adrenal insufficiency, and maybe the ACTH levels, maybe in the afternoon. And as you can see, in the one patient, the first patient, we were able to normalize ACTH both in the morning, 8 a.m., as well as 2 p.m. So the cumulative glucocorticoid dose that the patient was receiving was well received by the hypothalamic pituitary adrenal axis.
Thank you, Madam. For the time limitation, the speaker are here in the hall, so we can ask. So you can ask later on.
One quick question. Assalamu alaikum. Madam, very fantastic and precise talk about the adrenal insufficiency and replacement. We come across with one problem in our MDT meeting with rheumatologist. We were wondering what is the percentage and frequency of developing iatrogenic Cushing with pulse therapy, in how much pulse therapy could be there for the development of iatrogenic Cushing. In addition to that, we had a patient, she is on 40 milligram of hydrocortisone replacement therapy, 21-year-old student. We are facing three problems. The moment we start tapering down the dose, she starting developing clinical problems along with the biochemical abnormalities. In addition to that, she is particularly concerned about her weight. And on top of that, she said, I'm awake the whole night and I'm sleeping in the morning. What should be my strategy? So I would love to know your input.
What was your first question about?
The frequency and the prevalence
pulse therapy and effect on
how much pulse therapy is.
Okay, so I can't give you precise answers to that. We know that steroid therapy in any form, including inhalers and stuff, will lead to adrenal. That's the biggest group of adrenal insufficiency. The second, no, not the biggest group. The secondary is the biggest group, pituitary disorders. Tertiary is fewer. And in those patients who are on constant glucocorticoid replacement therapy, even in the secondary cases and some secondary and tertiary cases, they can be weaned off too. So provided you change your strategy and look at them. The 40 milligram of hydrocortisone split up into 2 or 3 doses is too high a dose. You need to go down. But you must remember the entity of glucocorticoid withdrawal syndrome. It's like when you treat Cushing's disease, patients feel very sick initially because it's like just like glucose. When you lower glucose, initially patients feel unwell because they're so used to a certain level. So similarly, the glucocorticoid withdrawal syndrome has to be remembered. So when you're dropping her dose, I wouldn't drop more than 5 milligrams at a time and leave her on that for a while, maybe 2-3 months, and then drop further so that her system gets used to it and she doesn't get the glucocorticoid withdrawal syndrome symptoms.
We did the way of dropping it, tapering down to 2.5 milligram. Her blood pressure was not behaving, her biochemistry was disturbed. So that's why we tried to taper it down to 20 milligrams. Still, she was complaining. The moment we increased the dose
So
to 40,
maybe she's one of those, these
Yeah.
are individual
Can-
responses too. You have to think that maybe her dose is higher than that.
Possibly.
Because there is inter-individual variability on how the body is handling it.
Yeah. We calculated based on body surface as well.
Yeah, but
and
there will be those kind of patients who
Yes.
don't fall into the whole common lot.
Can we give a trial of pred at night and then
So we're giving, I think you can give pred at night as well, but
Yes.
we're giving DEXA because of the braking difficulties. So midnight by all means. And our patients are sleeping very well, they're waking up very well, and they're happy. They've lost their pigmentation.
and the strategy to be awake the whole night and then sleeping in the morning.
That
and
the young
adrenal
people are doing
Huh.
anyway. Steroid deficiency.
she's
or
saying,
no,
I'm
people
working
are
on a
staying
computer,
up, watching their phones and things like that.
So could there be any difference in giving the dose in the same schedule when the person is awake the whole night and sleeping in the morning?
Whether or not they sleep, the circadian rhythm is related to your retina receiving the nighttime signals.
Okay.
And your circadian rhythm will be triggered whether you sleep or not.
Okay. Thank you.
Uh,
Thank you so much.
Thank you, madam. Now I request the panel of experts for their comments, valuable comments. Thank you.
Bismillahirrahmanirrahim. First of all, thank you very much, Dr. Khurshid and Dr. Tasneem, for your exciting talks. And special thanks to Dr. Saeed for traveling all the way from UK to attend PES meeting and for such a comprehensive talk. Thank you very much. Regarding first talk about primary hyperaldosteronism, we see that, as Dr. Khurshid mentioned, that this is the most important cause of secondary hypertension. At the moment, we need to educate our people, our primary and secondary care physicians, to check electrolytes as a part of their baseline workup for any patient who presents to them with hypertension. And it is also recommended that electrolytes, they are part of initial screening for any patient with hypertension. So many a time we detect hyperkalemia with hypertension, and this is the case in 70% of cases with primary aldosteronism. So this is the way we can detect so many cases of primary aldosteronism at earliest. So we need to train our primary physicians. Regarding second talk about steroid dosing, we see so many patients in our practical life who present to us who are using over-the-counter steroids, especially injectables, frequent injections, and tablets, especially the loose tablets. When they come to their qualified doctors and physicians, they abruptly withdraw steroids. On one side, these people, they have to face the consequences and the complications related to the overuse of steroid for months and years. But on the other hand, no, they have to face the consequences related to tertiary adrenal insufficiency. I would love to ask, what is your personal experience regarding the start of steroid in these kind of patients when there is tertiary adrenal insufficiency, and how you're going to monitor these kind of patients on their follow-up, especially the biochemical follow-up in cases when we do not have synectin available over here in Pakistan. My last question to Dr. Saeed. Dr. Saeed, I have a patient with a young female with adrenal incidentaloma with Hounsfield unit of less than 30, and there was no past history of hypertension. She never had hypertension in past. The biochemical profile, that was absolutely fine. There was no evidence of adrenal hormonal secretion on biochemical profile. Based on Hounsfield units, we opted for surgery, laparoscopic adrenalectomy. After laparoscopic adrenalectomy, the histopathology report suggested that it is a case of pheochromocytoma. She had never hypertension. She was asymptomatic in past, and she was asymptomatic after surgery. Metanephrine levels, they were fine before surgery as well as after surgery. So do we need to follow this patient for rest of her life the way we usually follow the patient with pheochromocytoma for the rest of their lives. Thank you very much.
Can you hear me? This is quite an interesting case because usually, under the stressful situation when the patient went through surgery, it's a very bad news when you open a patient and you notice that pheochromocytoma, as I mentioned in my case over here. It's quite surprising that all hormonal workup was normal. Intraoperatively, she was fine. It was just a histopathological finding of the tumor. I think it will be worth looking at, have a second look at the biopsy of this patient, because it's very rare that in a very stressful situation of surgery they didn't go up. Secondly, I think this patient will need an MDT approach about it, because firstly you need to do an yearly metanephrines on this patient, but for how long you're going to do it, of course we deal with the patient's life. I think number one thing which my advice would be, I think I've got quite a worthy people sitting here who will be able to advise as well, but my advice will be in this sort of situation, first have a look at again with the histopathologist to see whether that was really a pheochromocytoma. And the second thing is to monitor it for a year or so to see whether, because usually pheochromocytoma patient will require a lifelong monitoring of yearly metanephrines on these patients. If for the few years, because there aren't any guidelines now in this type of patients, it's negative, then it is whether worth following it up for rest of the life as well. That's what I would suggest.
Thank you. Dr. Sarwar, for a short comments.
So with the indiscriminate use of steroid for various reasons, the case you have described, we all see it on a daily basis. So the first thing you could do is, maybe जो आपका steroid का replacement dose है, you can't come to that because this patient is used to a much higher level of steroid. So I would tend to first put her on prednisolone and put her on maybe twice the replacement dose, so maybe 10 milligrams to start with, and then always try to keep tapering it. With the 10 milligram prednisolone dose given in the morning, if there is recovery of adrenal function, if you check before the next dose of prednisolone with a cortisol level, you may be able to see what's going on. So if your cortisol level is more than 10 in the morning and you come down to a very low dose like a quarter tablet of prednisolone, and in the morning, and the next day before the tablet you do a fasting cortisol level, and if it is above 10, clearly this adrenal is working and it is working well enough, so you can go down even further or stop and watch the patient. But if it is between 5 and 10, then that is this adrenal is not ready. So just keep tapering and give. It may take years for you to taper it off. But if it is less than 5, it is certainly this patient needs replacement therapy at the moment at least. So if you look at Kareem Miran's, the Imperial College paper, the one that I was showing you, the pharmacodynamics of the pharmacokinetics of prednisolone, they were actually able to take people off lifelong replacement therapy based on the fact that they were kept reducing the dose and the patients were fine and they were checking their early morning cortisols. And I may get the number wrong, but it's worth reading it. But they were about 21 out of 76, they were able to come down significantly with the doses to about 2 milligrams of prednisolone. And they were able to take 2 patients off long-term, lifelong prednisolone. But these were not primary adrenal insufficiency, secondary and tertiary cases.
Thank you. Thank you. Now Dr. Sarwar Mulak, for their comment.
Bismillahirrahmanirrahim. Excellent talk by all three worthy speakers. Although adrenal gland is a very small gland, but plays very vital role in maintaining very essential functions of the body. So timely diagnosis and proper management is essential to avoid morbidity and mortality. Thank you.
Thank you.
Thank you so much for inviting us, and it's a very humble experience to be here and share the session with all the senior and experienced and professors, people around, and giving excellent talks by Professor Tasneem and Dr. Khurshid, and very interesting cases by Dr. Saeed. And it was very informative, and I think very well summarized by Professor Najam. I think he eased our job and summarized it very well at the end. Thank you so much.
And thank you, respected speakers and chairperson. The last talk is in the Hall A. All of you are requested to go there in Hall A.